Good morning, everyone. A very happy new month to you. I am Bukola Daniels, and I welcome you all to another edition of our Vitro Retinal Lecture series. Today's lecture is lecture 10 in the series, and we'll be discussing the topic Geographic atrophy. We will delve into the accurate diagnosis and the evolving treatment landscape. This is our program of events for this lecture. I will be taking the welcome and introduction. Then we'll have the presentation from the speaker. Afterwards, we'll have an interactive session with the speaker, and then the closing remarks. Before we proceed, we would like to establish a few house rules. We kindly request that you turn off your cameras and mute your microphones for the period of the session till the interactive session, where we'll have the opportunity to make our comments and ask our questions. To give a brief overview of the Kunle Hassan Eye Foundation Academy, KHEFA. KHEFA is a member of the Eye Foundation Eye Care System. The Eye Foundation Hospital was established in 1993 with the vision to eliminate avoidable blindness through the provision of equitable, qualitative, quantitative, and affordable eye care to all. The Kunle Hassan Eye Foundation Academy, formerly known as the Deseret Community Vision Institute, oversees training for ophthalmology residents and fellows, mid-level ophthalmic practitioners, optometrists, and ophthalmic nurses. To introduce our speaker today, Dr. Christiana Dina. She is a consultant ophthalmologist and medical retina specialist at London Northwest University Healthcare, NHS Trust. She is also a honorary senior lecturer at Imperial College. She completed her general ophthalmology training and medical retina training in the north of England under the mentorship of retinal luminaries, such as Professor David Steele and James Talks, and subsequently completed her medical retina fellowship at the world-renowned Moorfields Eye Hospital. She is the founder of the Central Middlesex Ophthalmology Research Group. She has been chief investigator and/or principal investigator in over 20 multi-center clinical trials in retinal disease, including multiple pivotal trials. She is the Director for Research and Innovation at the London Northwest University Healthcare NHS Trust. She is the current Deputy Master for the Oxford Ophthalmology Congress. She's the Deputy National Lead at the National Institute for Health and Research Ophthalmology Specialty Group. And she's also the recipient of many research excellence awards. Her research interests are focused on diabetic eye disease, geographic atrophy, and sickle cell retinopathy. And she's passionate about the power of patient-centered research to deliver impact for society. Before I hand over the floor to Dr. Christiana Dina, I would like to kindly remind us that the CPD form we made available as usual in the chat box. Thank you so much. Dr. Dina, over to you.
Thank you so much. That was an incredible introduction, and now I have to sort of follow that up. It's going to be a bit difficult. I'd just like to say that let me just see if I can share my slides now. Just a second. Yeah, I'd like to say that I considered what to speak about today because the audience I'm speaking to in Nigeria, I'm from Nigeria, my parents still live in Nigeria. And as Francis mentioned earlier, I do have research interest in diabetes, which I think potentially is more relevant, or sickle cell retinopathy. But geographic atrophy is changing the landscape in retina just globally. And I think there is an opportunity in the African space to contribute to that conversation. So I thought I would speak to what we know currently about geographic atrophy, the evolving treatment landscape, and maybe highlight some of the knowledge gaps or missing gaps in terms of the African piece of the puzzle, which I hope maybe stimulates some of the audience to be inspired to do their own, to contribute to that knowledge gap, basically, to try to look at your own context and see what you can add to the current discourse in terms of geographic atrophy. So the title of my talk, as Francis kindly mentioned, is Geographic Atrophy, Accurate Diagnosis and Evolving Treatment Landscape. And I'm going to talk about how to recognize and diagnose geographic atrophy, the current treatment paradigms, and future treatments, evolving treatments in geographic atrophy. So the term geographic atrophy, I mean, I've heard that term since I started ophthalmology right at the end of medical school in 2005. And it's well embedded in ophthalmic vocabulary, but it actually describes, it is what it says on the tin. It is basically a term that was initially used just to describe lesions, so skin lesions, lesions in other parts of the body, because they appear to look like continents. So you can see, I don't know if you can see my cursor here, that's an area of geographic atrophy, and that's a map of Australia. You can see how, in the 1850s or so, they would have thought, well, that looks geographic. It's demarcated, well circumscribed. So that's where the term came from. In the context of macular degeneration, the term geographic areas of atrophy was introduced by Donald Gass in 1970. And as you know, he described many of the retinal diseases we treat today. And geographic atrophy specifically is characterized by the presence of atrophic areas that are visible when you look at the retina, and specifically in the macular area, and is a consequence of progressive loss of retinal pigment epithelium, photoreceptors, and choriocapillaris. So therefore, it's a disease of the outer retina. It's very prevalent. It affects approximately 5 million people globally. And in the UK and US is responsible for about a quarter of legal blindness registrations. In the West, macular degeneration is the highest cause of visual impairment. So it's a big problem. And with an aging population, it's becoming a bigger problem here. And when we think of geographic atrophy, again, it is one of the two forms of late macular degeneration. So, macular degeneration, essentially, you have early, where you just have drusen, intermediate, where the drusen is larger or with hyper or hypopigmentation at the level of the RPE. And then you have the late stages, where you have neovascular macular degeneration, which we will not be talking about today, and geographic atrophy. And there's a lot of focus on neovascular macular degeneration, certainly over the last, I want to say 20 years, but even before that, really because it causes rapid awareness of visual impairment and then rapid visual loss. And now, since the advent of the intravitreal antivascular endothelial growth factor treatments, intravitreal treatments, we have pathways that help us identify these cases and treat them quickly so we can have good outcomes. Geographic atrophy, on the other hand, up until last year, there was no standard of care. It was basically, we diagnosed it, we said there's nothing we can do about it, and the patient was discharged. And as I say, it's a growing problem with estimated 18 million cases of late macular degeneration combined by 2040. And in addition, in patients presenting with wet macular degeneration, about a quarter will have prevalent GA, in that whilst we talk about two forms of late macular degeneration, the diseases are more intercorrelated than we truly understand. They're really part of the same disease, part of the same spectrum. So they constantly coexist. And many times, even in patients who present with wet macular degeneration and at the baseline do not have macular atrophy, as we treat that tends to increase or actually become incident and then increase, and compromises or essentially steals away the vision you've gained by treating the exudative component. So how do we diagnose geographic atrophy? Now that we know what it is, as I said, a form of late macular degeneration, for a long time, no standard of care, progresses a little slower than the neovascular type. But how do you diagnose it? Well, like any of the other diseases that affect the outer retina, when making a diagnosis of geographic atrophy, it's really important to be clear that in this scenario, we're talking about geographic atrophy in the context of age-related macular degeneration, because most retinal specialists will be aware that there are other outer retinal diseases that cause atrophy, but are not atrophy secondary to age-related macular degeneration. For instance, late onset Stargardt's, or even features of hydroxychloroquine toxicity over time, or any of the cone rod dystrophies, as well as RPE rips, which sometimes a patient could present with an RPE rip. And remember, with that, you have a rolling over of the RPE and an exposure of the choroid. And if you're not looking carefully, you might think this is incident geographic atrophy rather than late stage neovascular AMD. So the cardinal features really are that you should have drusen in the eye, in addition to the atrophy that you're seeing. And age-related macular degeneration is essentially a bilateral disease, so you should expect features of early or late macular degeneration in the other eye. And this has to be in the context of a patient at least 50. And we'll talk about the fact that actually it's more prevalent the older you get. So those are the key features of making a diagnosis of geographic atrophy. And how do we do this? Well, imaging is a big thing in retina now. And we've had huge step advancements in the world of retinal imaging over the last 20 years. So traditionally, geographic atrophy, so in the time of Don Gass, for instance, would have been diagnosed with color fundus photography, because that would show you this well circumscribed area of with features of macular degeneration, and you can see through to the choroid. However, the edges around geographic atrophy on a color fundus photograph can be quite subtle and sometimes can lead to underestimation of the size of geographic atrophy. Fundus autofluorescence is now more commonly used, and this is a modality that detects lipofuscin. So lipofuscin is composed of visual cycle byproducts, which accumulate at the level of the RPE cells. They're toxic, essentially waste products. And when you have a lot of lipofuscin, you get bright signals from your autofluorescence. And when you have a complete absence, which is black, that tells you that that area has RPE cell death. So what I say to my team and to fellow ophthalmologists when I'm teaching, or to optometrists, is to think about autofluorescence in the context of diagnosis as quite simple. We're looking at shades of gray, shades of black and gray. So when you have sort of bright hyper autofluorescence, it is dying. And when you have black areas, it is dead. So the cells have atrophied. And except the exception is at the fovea, where you have a lot of macular pigment, which blocks autofluorescence, and that is healthy. So a loss of macular pigment can be pathognomonic of other diseases. So autofluorescence has a nuance to interpreting it, but in GA, it's straightforward. It helps you delineate the extent of geographic atrophy, and that sort of the loss of autofluorescence signal correlates with loss of function, because, as I said, in the areas where you have loss of signal, you have RPE cell death. However, it can be difficult to tell where the fovea is on autofluorescence sometimes. So oftentimes another modality is needed to confirm that. So I'm hoping you can see my cursor, going to point out this lesion here, which is the geographic atrophy lesion. It's multifocal in that there's one patch here and there's another patch there. But you can see on the edges, there's the sort of brightness around it. And that's the junctional hyperautofluorescence. And this is where you've got accumulation.
Sorry, Dr. Dina, your mic is muted.
Hi.
Yes, we can hear you now.
So all along, you've not heard me at all?
No, maybe just in the last 1 minute or 60 seconds, please.
Oh, okay. Okay, that's shocking. Right, I'm going to share again. Just a second. Okay, so I'll go back. Did you hear this slide? Hello?
Yes, we did.
Okay,
it's the next
great.
For about 30 seconds.
Okay, great. So this slide is just comparing color fundus photos to autofluorescence, just putting it side by side. So you can see the geographic atrophy on the color fundus photo here. Whilst you can see the features of the choroid coming through, you can see the large choroidal blood vessels, which is because you've got an absence of RPE. It's not as clear where the edges are as compared to here on the autofluorescence because of the incredible contrast between loss of areas with loss of RPE and areas that haven't. And this tiny sort of dark areas, these dots, are where you've got reticular pseudodrusen, which is a feature, a risk factor for developing a geographic atrophy and progression of geographic atrophy. So OCT, like I said earlier, can be quite difficult to tell where the fovea is on autofluorescence. But OCT, again, the proliferation of OCT in retina has really changed the landscape for how we diagnose things. I came into ophthalmology in 2005, straight out of med school, and that's around the time we started to have OCT in the clinics. And 2006, we had ranibizumab, the first licensed anti-VEGF in the clinic. So I feel like my timing was perfect because I don't really have a time of practice where I haven't had OCT access, which is great in one extent, but obviously very privileged and spoiled in another extent, because I do know that you do need clinical skills to be able to detect some of these things. But we're over-reliant, well, I've been over-reliant on OCT, I have to admit. And what it does is it's depth resolved, so it allows you to see not just the 2D image, but also the semi-histological layers of the retina. And in geographic atrophy, it has really changed the game, because not only can you detect the extent of geographic atrophy, you can tell whether the fovea is involved, but also you can pick up high density, higher order features of the retina and RPE and choroid that are basically precursor lesions to geographic atrophy. And you can imagine that in the context of a clinical trial, that's really important, because when you're looking for treatments or new treatments for a condition, being able to know to be able to tell the progression of that disease, the natural history of that disease, is so important, and to monitor it, because then you might be able to find earlier biomarkers or endpoints that tell you your drug is working, as opposed to depending on extent enlargement, which takes longer. And the longer a clinical trial takes, the longer the treatment takes to get to our patients, and the more money it costs as well. And while we're doing all of that, people are losing vision. So OCT is the modality of choice for diagnosing geographic atrophy, and there's a lot we can do now with OCT to help us with sort of understanding more about GA. But I will say that multimodal imaging, so OCT, autofluorescence, color fundus, all of that gives complementary information about geographic atrophy. Just to highlight this consortium, the CAM group, a group of international AMD and retinal imaging experts that worked together, came together in 2017 or so to provide a consensus terminology and definition for atrophy. And what they agreed was that geographic atrophy in the context of age-related macular degeneration essentially needs to meet three criteria. You need to have a region of choroidal hypertransmission. And here, again, I'm hoping you can see my cursor. You can see this area of retina. You can see, the RPE here, which is the brightest outermost line, and you can see the choroid. But as here, you can see the light goes right through. You can see the shading. That's choroidal hypertransmission, and it's because you've got loss of RPE, and so you haven't got the pigment of RPE to block the light, so the light is going all the way through. So part of the definition for geographic atrophy on OCT is that this region of hypertransmission must be present and must be at least 250 microns in diameter or more.
Please excuse me, Dr. Dina.
Yes.
We can only see your image in full screen. We can't see your slides in full screen. So please kindly share your slide in full screen.
It's shared here in full screen, so I'm not really sure. Let me just see.
What we are seeing right now is a video of you.
Oh,
full screen. Yes.
That is odd. Let me see. Can you see my slides now?
We can see your slides.
But it's on the top right corner.
Oh, I see.
No. No, I think it's from your side.
Bukola, I think it's from your end.
Okay, that's fine. Apologies. Please, you can continue.
Okay, so can you see my slides, everything, or just me?
Your slides.
Now, when I go to, this is me sharing full screen. Can you see the slides fully?
Yes, we can.
Excellent. Okay, so I'll just go back again to defining geographic atrophy. Three features. Choroidal hypertransmission has to be at least 250 microns. You have to have a zone of attenuation, which is thinning, or complete disruption of RPE. Again, at least 250 microns. And also overlying photoreceptor loss, right? In the absence of RPE tear, because like I said, this can happen when the RPE simply tears, for instance, when you have a PED in neovascular AMD and the RPE rolls over and tears, you can have this loss. So you've got to make sure there's no RPE tear. But in this sort of native condition, this is the definition, the minimum definition for geographic atrophy on OCT. And they described other precursor lesions as well, but that's the geographic atrophy itself. And in terms of classification, geographic atrophy can be classified as foveal involving or non-foveal involving. And it is difficult, like I said, sometimes to tell whether it's foveal involving or autofluorescence. So OCT is important. So you can see this here. This is a patient on my left, the leftmost image with foveal involving geographic atrophy. And here, the lesions are not involving the fovea. Here's the fovea. But you can see the fovea looks very similar to these lesions, which is why it's really useful to use OCT here. It can also be classified as multifocal. So you can see these patches here, or unifocal, just the center. And this is all important because multifocal lesions grow faster than unifocal lesions. Extrafoveal lesions grow faster than foveal involving lesions. So again, it helps, this understanding helps you counsel your patients. So what causes geographic atrophy? Well, it's multifactorial. It's thought to be triggered by oxidative stress caused by internal stressors, so things within our body, but also external stressors. We know that with age, you get accumulation of extracellular deposits, drusen, and intracellular deposits, lipofuscin, as I mentioned earlier. And these deposits and other products of oxidative stress trigger inflammation via many pathways, including the complement pathway. And that leads to the RPE dysfunction, which then leads to photoreceptor, then RPE cell death. We think now from a lot of the current studies, including AI algorithms that have been used to study progression of geographic atrophy using OCT slabs, that the photoreceptor dies first before the RPE layer. But the dysfunction, we think, starts at the choroidal and RPE level. So what are the risk factors for geographic atrophy? Age is the key one. The prevalence of geographic atrophy quadruples for every decade of life. So you can see as you get older, the proportion of people, and this is from a European registry, the proportion of people start to approach almost, well over 20% by the time you get to 90 years of age. Genetics, and that shows that, you know, the risk for developing, the variability risk for developing AMD, genetics accounts for about 55% of that. Ancestry, European descent ancestry is higher and African ancestry is lower. But I argue, and that's probably true anyway, because I think we would see more of it if it was more prevalent, but there are very, very few studies of geographic atrophy or indeed AMD in the African population. Modifiable risk factors, smoking, 3.5-fold higher risk of GA with if you have more than 40 pack years. Unfavorable lifestyle, so fewer portions of fish, vegetables, and fruit, in addition to genetic risk, increases the risk about 2.5-fold. And so those are the risks that are those are the non-modifiable risks. Then in terms of natural history of this disease, 80% of people with geographic atrophy or geographic atrophy lesions start outside of the fovea and then progresses over time to involve the fovea. Why is this important? If you look at this diagram here, this yellow diagram, let's assume this is the GA, and over time it grows, and then finally affects the center. It means that when you've got a patient in your clinic and you're checking their visual acuity, remember that a lot of that is driven by the fovea, what we check in our clinic, the ETDRS chart, the Snellen chart, the Logmar chart, that's high contrast visual acuity, and it is driven by the fovea. But this patient has a growing scotoma, probably finding it hard to work in low lighting environments, difficult to read probably when you have this bilaterally. But when they come to your clinic, they keep reading really well. So sometimes it can be quite late to diagnose this or to understand how much of a problem they're having because their fovea is spared. And just to again highlight that on average, again, in these large studies, the median time to go from here to this, to foveal involving, is about 2.5 years. So it's slow to progress, slower than wet AMD, but not that slow. And as you go from there to there, you start to get worsening visual impairment under low light conditions, some difficulties, particularly if it's bilateral scotomas, before you then lose central vision and become legally blind. And you'll see here on the left, progression rates as it gets bigger varies by baseline lesion. So that's the other thing about geographic atrophy, that the growth rate varies. It's extremely heterogeneous. Some people go from here to there. Like I said, median is 2.5. Some people get from here to here in under a year, and others will die before it gets to the center. So picking out who will benefit from some of the treatments we've got coming onto the market now is going to be quite an art and a science. This is again highlighting the natural history progression, what we know about it. In a recent large UK study, we found that 71% of these patients with geographic atrophy were ineligible to drive. 31% lost more than 15 letters within 3 years. And the mean loss of visual acuity in the better seeing eye over 2 years was 12 letters. So this is not a benign disease. This is something that affects people significantly. And we are learning more about the predictive factors of fast progressors, because we need to know who is going to be affected by these diseases in their lifetime as we start to think about the current treatments we have on board. So we know, for instance, that the junctional pattern I showed earlier, the diffuse pattern, if it's diffuse, means you're more likely to progress faster or banded. The size of the lesion, as I said, the position of the lesion, the presence of things like reticular pseudodrusen. These tell you how quickly this geographic atrophy can progress. This is one of my patients. This was them in 2018. You can see the vision here is almost perfect, 6.6, and within 4 years, you can see now they're at the fovea. You can see the OCT, this large transmission, choroidal hypertransmission. The fovea is involved, the photoreceptors and the RP are attenuated, and the vision is well below driving and almost 660. Another patient of mine in 2021, and within 2 years, they've gone from just small patches, that's the fovea there, to massive scotomas in both eyes. Essentially, we had to register them partially sight impaired. And I wanted to highlight this to this particular audience because we're talking to an African audience, and I'm presenting all this data that is very heavily European based. And I think this is important, and I highlight this a lot in my deputy national role here, that we need to do more as a community, as an ophthalmic community, to make sure that our trials and our natural history data and our genetic wide association studies reflect a generalizable cohort, because we know that individuals react differently to treatments. There are intrinsic factors like age, sex, ethnicity that determine how you respond to a drug, to a treatment. And there are extrinsic factors like diet, physical activity, concomitant medication. But we know that these factors, the differences in them can result in meaningful difference in outcome for the individual. And in the NHS, within my role, one of the things I emphasize is the need to include underserved groups, and in this particular case, ethnic minorities in our clinical trials and our studies. And this is because, for instance, in diabetic retinopathy, there's a difference in phenotype between ethnicities in terms of where your diabetic lesions are. We know that people from the Far East have more predominantly peripheral lesions versus people from, for instance, South Asia. We haven't done these studies in the Black African context, so it'll be interesting to know if there's a difference and if therefore treatments in this sort of disease should be different. Similarly, there's a difference in retinal thickness by ethnicity. There's a difference in vascular density and foveal area zone by ethnicity. And there is a difference even in GA progression by ethnicity. And this is a study done in Asians versus non-Asians. But again, there's no African representation or even Black African ancestry in these studies. So we don't really know how this works or what the progression of GA is in the African context. And this just underlines all of that because we know that there's underrepresentation globally for instance, this is from diabetic macular edema trials, but even in glaucoma trials, which is very prevalent in the African context, there's an underrepresentation of people of African ancestry. So there's very sparse data on geographic atrophy in the African context. However, I will tell you where we are here in terms of the complement pathway, the current treatments we've got, and hopefully where we're going. So the complement system is the most implicated in geographic atrophy, but you can see there's many other pathways that have been implicated as well. There is histological data, GWAS data, and natural history data that heavily implicates the role of the complement system in geographic atrophy. The complement system consists of 3 pathways activated by different factors which converge at the C3 level, and then you have a cascade, or rather a chain reaction, that then leads to destruction of what should be pathogens, because you have to remember the complement system is part of your immune system that your body uses to get rid of pathogens. But what happens in geographic atrophy is that this system is compromised, and instead of attacking pathogens, it attacks healthy cells. So this is probably an image you learned in medical school and decided to absolutely get rid of because it's complex. However, the way I think about complement system is that it's a chain reaction. It's like a burglar coming into your home and sets off the light sensors, which then sets off the alarm bell, which then sets off the local alarm at the security office, which then sets off something else at the police. Then the police come and then they catch the thief. That's how I like to think about it. And the current treatments that have just been approved for the first time ever last year, pegcetacoplan, basically acts at the level of C3, prevents this C3 from starting this cleaving into C3A, C3B. So stops the reaction, the chain reaction further downstream. Whilst Izervay, which is the other agent that has just recently been approved as an intravitreal treatment, inhibits C5 here, so further down, and stops the inflammation going further. Like I say, I use this quite often to talk about the pathway and how you basically want to stop the chain reaction. And something like pegcetacoplan attacks it at this point, whilst Izervay, the thief is probably the alarm is already off, and then he stops it. And this is basically the backing for this that the FDA used to approve pegcetacoplan, and it basically, this is the large trials that were done. Oaks and Derby, our team were contributed the most patients in the UK to these studies, and it showed that giving these patients intravitreal injections, like Avastin, but of pegcetacoplan, reduced the growth rate of geographic atrophy by approximately 20%, more so in those that were extrafoveal than those that were foveal. And the Izervay study, GATHER2, which was then, which is the drug Izervay that was then approved in August, showed essentially similar results. Every other month, 19% reduction. But there are pros and cons with these new treatments. The pro is that they reduce GA growth rate. And remember, we want to stop GA growth rate. We want it to stop outside of the fovea. But at this point, they don't stop it, they just slow it down. And these drugs have conclusively shown that they can slow it down. But the negative is that they did not show any functional benefit yet. And also there's an increased risk of macular neovascularization over time with increased dosage. And more recently, there's now a risk of rare but potentially devastating occlusive vasculitis with pegcetacoplan. And also there's the logistical burden of having injections every month or every other month to patients. And our group did a study which we've published looking at acceptability to patients. And in essence, most patients said they will struggle to accept the treatment for geographic atrophy that does not cure their disease or stop it, but just slows it down and means they have to come to hospital every month. Now, at least we've got those two things. And I like to think of those two treatments as like the Macugen of the GA generation, because at the start when we had Macugen, it was just the beginning. Now we have more improved treatments like faricimab and Eylea and so on. So similarly, we have things in the pipeline. And these are just 3 trials that I'm personally involved in that are looking at geographic atrophy. One of them is the ANX007 study. And it basically attacks, it's basically a anti-C1q. C1q is above the C3 level, and it's basically stopping the classical components of the complement cascade. So really stopping the thief before it even gets to the door. That's the pathway with ANX007. And the idea is that if it stops this inflammation, then you protect photoreceptors. It is dosed again into the eye monthly or every other month. And the phase 2 study showed, that slide isn't here, but the phase 2 study showed protection of photoreceptor loss and protection from losing 3 lines of vision at 1 year. And now we're just about to move on to the phase 3 study later this year. Elamipretide is another agent that we're studying. and it is basically helps to protect the mitochondria and limit oxidative stress and protect the mitochondrial membrane and structure within the RPE cells. And this is interesting because it supports mitochondrial health just across the rest of the body. And the treatment elamipretide is dosed not into the eye, but actually in the skin, subcut on a daily basis. And some of the patients that have been involved in the early phases have noticed an increase in energy as well. You can imagine if you're 80, your energy levels might not be what they used to be, and having something that not just slows down your progression, but also gives you a little bit more energy might actually be interesting. The concern, of course, is whether patients will actually inject themselves every day, but we're moving on to the phase 3 of that, because the phase 2 showed reduced progression of photoreceptor loss by over 40%, which is phenomenal and enough to move forward. And then the last one is tinlarebant, which is another study that I'm involved in. And this is tablets, daily tablets. And what this particular treatment does is it reduces retinol delivery to the eye as a means of slowing progression. And this was found to be effective in Stargardt's and is now in phase 2 or 3 in Stargardt's disease. And because of the similarity between Stargardt's and geographic atrophy, the thinking is that it might also help slow down progression in geographic atrophy. So we're now doing the phase 3 study called Phoenix in our unit, where we're giving these patients daily tablets of tinlarebant to see if it reduces cell death and loss of vision. So in summary, we're entering a new era in retina beyond anti-VEGF. We have 2 approved treatments for geographic atrophy in the US and currently under consideration in the EU and the UK. My group have patients on these treatments because we are involved in all the trials. Then there's many promising treatments in phase 3, and there's much more in phase 2 and phase 1 that we're also hopeful about. There is scope to understand the pathogenesis and the protective features of geographic atrophy in the African context, because there's very little in the literature about that, and indeed about AMD in general. Thank you for listening and for your attention. And I'm looking forward to some healthy discussion.
Thank you so much, Dr. Dina. Thank you so much. A very thorough lecture. I must say, very, very profoundly insightful and detailed. Thank you so much. We'll be taking the questions now. I can see a question from Dr. Dada Teresa. Can atrophic ARMD be delayed in the Nigerian population by encouraging taking lutein-containing tablets, antioxidants, and diet information, as access to treatment may be difficult for most? Is there a benefit to taking these tablets without evidence of ARMD? Example, in those with a strong family history?
I think that's an excellent question. So the evidence for the AREDS tablets is from the AREDS 2 trial, which is, what most people prescribe that for. And the evidence for any benefit is only in those with intermediate macular degeneration. So that's with large drusen, larger than 125 microns, or with hyper or hypopigmented RPE. There was no evidence in any other subgroup. Again, these studies didn't really have people of African descent, so you could extrapolate this data, but you would be doing so with a lot of caveats, because the thinking is, if pigment protects us from AMD, and the prevalence of AMD in the African context is very, very low, then is AREDS likely to do anything? Then secondly, there have been follow-up studies that have suggested that a diet rich in oily fish, green vegetables, foods that that have antioxidant properties, is just potentially as effective as using AREDS tablets. So from that perspective, I would probably lean more towards lifestyle factors. But I take your point about strong risk factors. And I think in that group, given that the AREDS tablets don't do any harm, then you don't lose anything except maybe a little bit of money by using them. But I would urge studies to be done in the African context. Sorry to bang on about that, but I think it's so important. And I think it's really important that we actually look at our patients and collate our data and study the features in them to contribute to the knowledge gaps, because there is huge knowledge gaps and there are differences in how we respond to things in some diseases. Some things it's the same, but we don't know that. Even hypertension tablets, for instance, there's a variability by ethnicity in some cases.
Thank you so much, Dr. Dina. Do we have any more questions? If you have a question or a comment, please just type in the chat box. Thank you.
So I have a question. Do any of you see patients with geographic atrophy in your clinics, or even actually with wet AMD? I've seen a few patients with both in my clinic in London. With IPCV, I see quite a few Africans, of course. Although again, I think it'll be useful to do a prevalence study on that. Wet AMD, I see a few as well. I just wonder, in terms of the spectrum of macular degeneration that you see in your clinics.
Okay, Dr. Dina, thank you. Yeah, we do see, if I would put the frequency, I'll say PCV, then wet AMD, then dry AMD, geographic atrophy.
Yeah.
Geographic atrophy, since I've been trying to look at it, I've discovered that it's really quite very few. You don't see much of them.
Yeah.
Just a few. And then sometimes some of them that I see, I'm even asking myself if this is really geographic atrophy or not.
Right.
But for exudative, yes, we are seeing, I mean, definitely we do see that, and there are quite some reports on that. PCV is like a flood. We see that a lot.
Yeah.
We see that a lot. Yeah. So, I mean, this is just a cursory evaluation of what we see.
Yeah, no, I think PCV in the African context is quite interesting, particularly because, you know, to do studies around the choroid and, you know, whether, you know, how thick our choroids are and, you know, the whole Paki spectrum thing, how well it responds. My concern really is that, okay, obviously with PCV, there's PDT, there's anti-VEGFs, and people are starting to look at studies to see whether if response to anti-VEGF varies by ethnicity. But when the geographic atrophy treatments come, well, I expect probably there will not be much uptake in Africa, because if the prevalence is really little. But even the few people that do have it, we don't know if it's going to work because they're not in any of the trials. So this is the thing, like really just looking at, and I think also the fact that we don't have geographic atrophy probably says something about we're being protected from it, and understanding what protects us might be able to help us with finding treatments for those who are not protected.
Well, yeah, the genetics, if I look clinically, I don't see a lot of Caucasian patients, just a few here and there. But the few I see once in a while, the older ones, you see, at least you see one drusen somewhere.
Right.
I've looked into so many African eyes. You don't see that number of drusen in their eyes. And so it's, I think there must be some, like for every disease, genetic and environmental factors, and which I agree with you, we really have to look into to be able to see what are those factors in Africans. I guess now that there is a treatment for geographic atrophy, at least for me, it's making me look out more for it. I mean, because before, when you can't really tell a patient, okay, you have this, and then, okay, what do I do about it? We just watch you. But now you can at least give them some hope. That makes you look out more for it. I think we'll pick up more, and of course, we really need to look at those factors that seem to reduce the frequency of what we see. And
Absolutely.
I'm sure that,
yeah. So there's a question here that is there any use of fundus fluorescein angiography for GA care, or is autofluorescence adequate? So I would only do if the point is to diagnose GA, you actually don't need FFA, because autofluorescence, OCT, fundus photography, all of that gives you all that you need. You might do FFA if you're suspecting something else, or if you're trying to find, a CNV, but even then, OCTA is pretty useful. So no, it's not something I use for GA unless I'm looking for something else.
All right, thank you so much, Dr. Dina. Do we have more questions, comments? We have about 2 minutes to round up this interactive session. Kindly drop your questions or your comments in the chat box. We'd like to apologize for the unavailability of the CPD forms. We've been having some technical issues posting it. So we kindly ask that you drop your email addresses so we can send it directly to you. Thank you so much. Apologies once again. In the absence of any question, we can move forward. I want to thank everyone for participating in this lecture today. Thank you so much, Dr. Christina Dina. A very insightful lecture. Thank you for taking out the time to share out of your wealth of knowledge. We appreciate you. Thank you so much.
Thank you for inviting me.
You're welcome. We also want to remind everyone that the Vitreoretinal series takes place every first Wednesday, I beg your pardon, of the month, and we'll keep you posted on the next lecture. Okay, we have some comments. Dr. Emmy says, thanks a lot.
Oh, I've seen
Dr. Bassi says, thank you, Dr. Dina, for that insightful lecture. And Dr. Miriam from Kano. Dr. Ome says, thank you so much for the lecture.
Thank you, everyone. That was great.
Thank you very much. Please kindly drop your email addresses so we can send the CPD forms to you. To view our previous lectures in this series, we've shared the YouTube link in the chat box. You can visit our YouTube page, KHEFA YouTube page, and view the past lectures as well. And today's lecture will also be posted on our YouTube page. Thank you so much, everyone. Have a great day ahead.